Management of diabetes is very important in terms of it being very personalized and individualized to a particular individual. Now, they say diet therapy is really the cornerstone of the treatment and management of diabetics. And two other factors, the diet, the drugs, and exercise, all three play an important role in the management of a diabetic. And of these three, diet really plays a very important role, mainly because we have two types of diabetics. One are the insulin-dependent diabetics, and the other are the non-insulin-dependent diabetics. Now, in the insulin-dependent diabetics, insulin is given, and so diet and insulin, along with exercise, plays a role in the management of a diabetic. But in the non-insulin-dependent diabetes, it is mainly the diet, along with exercise, which controls most of the symptoms of diabetes. Now, why is diet an important factor in the treatment of a diabetic? Now, as you know, diabetes is a metabolic disorder where there is a disturbance in the carbohydrate metabolism. And one of the main sources of carbohydrate to an individual is the food we eat. And although we say diet is very important in the management of a diabetic, it is not easy. Because as you know, the diet which we all eat is based on various factors. And it is something which we have acquired over lifelong living, where whatever we eat is dependent upon our economic level, about our cultural patterns at home, about the availability of the mother in terms of cooking and facilities available, economic factors, social factors, cultural factors, whether you're vegetarian, non-vegetarian. All these various factors bring about a person's individualized diet. So when we say we have to control the diet in diabetes, it is not easy for any one person to change the diet, mainly because it's something which has been acquired over a lifelong time. So when we plan now the nutritional management of diabetics, we think of it more in terms of medical nutrition therapy, where it is a treatment done in coordination with the other members of the medical team, which includes a physician, the nurse, the other social allied or the paramedical workers. And the dietitian plays a role in terms of managing the intake of the patient, and therefore it has to be done on a personal level. Now, when we speak in terms of medical nutrition therapy, what do we mean? It means that the diet is individualized to suit a particular individual. Now, there are basically 4 steps in medical nutrition therapy. First is the assessment of the individual's background. Now, the assessment includes various factors. One is a nutritional assessment, that is based on whatever he has been taking all this time. What is his weight? What is his height? You have different ways of measuring the nutrition assessment. One is the anthropometric, which is usually the height and weight to determine whether the person is at his correct weight or not. It could be the biochemical parameters, like what is the sugar levels, what is the lipid levels, how is the liver functioning, kidney functioning, and so on, which will be determined by the biochemical parameters. And then the clinical examination of the patient to see how his physical condition is and whether he has any signs of deficiency and so on. So after assessing all these various factors, we come down to what we speak as a nutritional status of the individual. Now, this is an important step. And now once we decide on the nutritional status, for example, if we take his height and weight and find that he's overweight, one of the predisposing factors for diabetes is obesity. And quite a number of the non-insulin dependent diabetics, if you can reduce his weight, you'll find many of the symptoms of diabetes come under control. And therefore, it is very important to see that the person's weight is at its desirable levels. Now, how do we do this? So we have various methods of assessing. So once we assess the individual status, next one is to identify what is your nutritional goal. Now, when you take a diet evaluation of the patient, you will find out whether he's taking more than what he should actually be taking. Is that contributing to his weight? Is his activity very low, and therefore is that the reason why he's putting on weight? Or it could be that his dietary intake in terms of other nutrients is not adequate, therefore how should we improve that? So there are various factors which you can assess from the individual's diet and then try to develop goals for the individual patient. Now, these goals are different. It can't be just goals which are laid down for the patient because it is a lifestyle modification. So you have to sit with the patient and build a rapport with the patient and try to make the patient himself identify the goals which he can achieve and which he can follow. So the second step after assessment is to determine what individual or nutritional goals you have that for that particular patient. Now, this is worked along with the patient. Maybe the patient can continue the same diet if he wants to lose weight by increasing his activity. Or it may be that he would like to keep the same activity, but he would like to reduce the intake. So you have different ways in trying to achieve the particular goal. Then it could be a short-term goal or it can be a long-term goal. For example, when you take a dietary evaluation of the patient and you find his intake of fiber is very low. Now you know that his dietary fiber intake should be higher. Therefore, you try to, along with the patient, try to see in what ways you can increase the dietary fiber of the diet without actually changing the whole pattern of his dietary pattern. So once we decide on what the goals are, next step is what is the step you take to achieve that goal. Now, this could be done in different ways. Now, one, it could be by controlling the diet very rigidly, by weighing what you're eating, carefully examining what you're eating, and therefore maintaining a diet. Or it could be just by educating and saying what is good for you, what is not good for you, what are the problems which are being caused by eating the way you are doing, and so on. So the intervention, now once you achieve you lay down your goals, then you plan on how you're going to achieve those particular goals. And once you put down your plan, the last step is to see whether your plan has been, objectives have been achieved. Now, for instance, you want a person to lose weight. You may put down your goal as you would like him to lose, say, 1 kilo in a month. You have to evaluate maybe after a month and see whether he's actually lost the 1 kilo or not. If he hasn't lost 1 kilo, then it's up to you to see now what is the next step. How should you modify your plan again so that he will lose his weight? You have a target and you have to achieve that target. Now, in diet therapy, there are various goals which you could have, and this should be individualized, should be realistic, and should be something that the patient should be able to achieve. Now, the first goal we usually have is to see that the person tries to maintain his desirable body weight. Second, in a diabetic, is his blood sugar levels will be not under control. Therefore, your aim should be to keep the blood sugar levels by managing the diet as close to normal as possible. Then one of the complications of diabetes is cardiovascular problems. So if the individual has lipid levels which are deranged, then it's up to you to try to, along with the patient, to see how you can correct the lipid levels. Then it is important in a diabetic that not only do we control the food intake, we have to control the intake, the timing of the meals we take. Therefore, if the individual is not having regular timings, then you have to plan with the patient how you could alter this to bring down his blood sugar levels as close to normal as possible. So these are the main goals you have. One is to see that the person maintains his desirable body weight. Second is to keep the blood sugar levels as close to normal as possible. Third is to see that the lipids are at desirable levels and to delay the onset of complications, which could be nephro complications, could be cardiovascular complications. So try to plan the diet in such a way that these complications are delayed or postponed as far as possible. And this has to be carefully monitored by the physician, the dietitian, and the nurse together. Now, when you are educating a patient, you have to educate the patient on how he's going to achieve it. Now, we have various ways in which we calculate the individual's desirable body weight. One is known as a Harmony method, where we can calculate the weight in terms of pounds, and we say for a man, for the first 5 feet, it's 106 pounds plus 6 pounds for each additional inch. Now, if it is a woman, we say 100 pounds for the first 5 feet and then 5 pounds for each additional inch. So if a man is 5 feet 7 inches, we say it should be 106 plus 42 is equal to 148 pounds. And normally in a diabetic, we try to see that he maintains at least 5 to 10% below his ideal weight. So if we are aiming for a diabetic, we would try to see that he stays around about 140 pounds or so. That would be his desirable body weight. Now, another way we can do it is in terms of finding out his weight in kilos, which is known as the Broca's index. Now, in this, we say the height in centimeters minus 100 will give you again the weight in kilos. Now, if you calculate that and then work 5 to 10% less of that, will give you roughly the desirable body weight. Now, what is the factor in our diet which controls or regulates the weight? Now, it is actually the energy which we consume, which is really coming from the carbohydrate, protein, and fat in the diet. Now, in a diabetic, we said it's a metabolic disturbance, and the main nutrient which has a disturbance is the carbohydrate. And the blood glucose which comes into the bloodstream, or which is increased or at normal levels, all depends upon the amount of carbohydrate we take in the diet and the factor of insulin which controls the levels of glucose. Now, in a diabetic, either the insulin is not adequate or it's not functioning effectively, and therefore the blood glucose levels are not maintained at the desirable levels. Therefore, we have to control the amount of carbohydrate an individual takes. So roughly we determine based on the height, we decide what is the calorie requirement of that particular individual. And then based on the calorie, then we have to decide how much of this calorie should come from carbohydrate, protein, and fat. Now, because it's a disturbance in carbohydrate, we try to maintain the level at about 60 to 65% of the calories for a non-insulin dependent diabetic. Now, if it's an insulin dependent diabetic where the insulin is given according to the carbohydrate intake, in that case we reduce the carbohydrate levels to about 50 to 55% of the calories in the diet. Now, the other two factors which control the calorie, which contribute towards the calorie, are the protein and fat. Now, as you know, protein is not taken just for energy. Protein has other important functions in the body, and therefore we have a minimum requirement of protein which is about 1 gram per kg body weight. So roughly in the diet, we say about 10 to 15% of the calories should come from protein. And the remainder of the calories, which is about 20 to 25%, comes from the fat. Now, of these three, you find the protein has to have other functions in the body. Fat really contributes to the calories. And one of the problems and complications of diabetes later on is cardiovascular diseases. And therefore, we try to reduce the fat intake and see that the level is maintained below 25% of the calories. Now, when we talk about carbohydrate in the diet, roughly we are saying about 60 to 65% is from the carbohydrate contributing towards a calorie. Now, what type of carbohydrates do we have in the diet? Now, normally we say we have the simple carbohydrates and we have the complex carbohydrates. Now, simple carbohydrates give rise to easily available glucose, and they don't require much digestion, and therefore glucose is rises in the blood quite quickly. Whereas the complex carbohydrates are more complex, and therefore they take a longer time to digest, and therefore longer time to release the glucose. Therefore the levels which come into the bloodstream are on a slower level. So we try to tell diabetics to cut as far as possible from their diet the simple carbohydrates and consume more of the complex carbohydrates. Now, in the complex carbohydrates itself, we have a factor which is known as a glycemic index. Now, we find among these complex carbohydrates, some carbohydrates tend to lower the blood sugar levels less than compared to some other carbohydrates. For example, if it's polished and white rice, the glycemic index is higher than if it is red or unpolished rice. Same way, some of the carbohydrates like whole grams and pulses have lower glycemic index compared to the cereals. Same way, vegetables and fruits also will have glycemic index which is lower than the cereals, but at the same time higher than the whole grams and pulses. Now, all these, the normal sources of carbohydrate in our diet are mainly cereals, dals and pulses, vegetables and fruits. The non-vegetarian items don't contribute towards the carbohydrate in the diet. They are mainly protein and fat. And so for a non-vegetarian, it's easier to control the carbohydrate to 60 to 65% of the calories. But in a vegetarian, to control it to 60 to 65% is more difficult because cereals and dals both have higher amounts of carbohydrate. And therefore, we add more of things like cottage cheese or paneer, and then we add milk and milk products to reduce the amount of carbohydrate coming in the diet. So in terms of carbohydrate, we think in terms of type of carbohydrate, and we think in terms of the glycemic index of the carbohydrate, and then we think in terms of dietary fiber, which is again a carbohydrate, but it is not available in terms of calories to the body because it is not digested in the human tract. So this dietary fiber contributes to the diet in terms of satiety value, satisfying aspect, And of the dietary fiber, we have two types. One is a soluble fiber and the other insoluble fiber. Now, insoluble fiber contributes in terms of giving fiber, satiety, and prevents constipation to the individual. In terms of soluble fiber, these are the ones which actually lower the glycemic index, and they contribute in terms of lowering lipid levels and also helping to keep the blood sugar levels at better control. So in a diet, we try to see there's a minimum level of dietary fiber, and normally we say roughly 25 to 28 grams per 1000 kilocalorie. So when we speak in terms of carbohydrate in the diet, we say 60 to 65% of the calories should come from carbohydrate. We think in terms of making it complex carbohydrate and not simple carbohydrate. We think in terms of having carbohydrate which is high in dietary fiber, and we also think in terms of having amount of soluble dietary fiber in the diet. So these are factors we consider when we come to the carbohydrate. Now when we come to the protein, now the source of protein in the diet, mainly because we eat such a large amount of cereals, they contribute quite a bit to the protein content in the diet. And for a vegetarian, the other source of protein are dals and milk products. And when we think in terms of protein, it is important to think in terms of quality of the protein. For instance, if you take cereal, the quality of protein is not as good as the quality of protein of milk. So we try to make a combination of the vegetarian proteins like cereal and pulse to improve the quality of the protein, or adding a little milk and milk product to the diet to improve the quality of protein. Now non-vegetarian foods is no problem because the quality of protein they're all of good quality. So egg, meat, fish, milk, all these are good quality proteins. So the protein in the diet comes from both the cereals, pulses, as well as the non-vegetarian milk and milk products. Then we come to the fat in the diet. Now what are the sources of fat in the diet? We have two types. One is called the invisible fat and the other is a visible fat. Now the visible fat is the fat we use for cooking. Now for instance, we use oil in cooking. We add, when we go out for a meal, we add ghee on top of the sambar to increase the flavor. Now that's again the visible fat. Then we may have a lot of fried food where we use a lot of visible fat in cooking. Then we use butter along with bread, which is a visible fat. Now again we have the invisible fat. Now the invisible fat is part of the fat or the composition of the food. For example, if you take chicken, meat, fish, etc., they have fat in it. Whereas if you take cereals and pulses, they are very low in fat, minimal amounts of fat, so they are not calculated in terms of fat purposes. So when we say in terms of fat, we say not only should we see that the amount of fat in the diet comes to less than 25% of the calories, we also think in terms of the type of fat. So we have basically three types of fat. One we call fats are made up of fatty acids, and we have three types of fatty acids. One is known as the monounsaturated, the saturated fatty acids and the unsaturated fatty acids. Now in the saturated fatty acids, we say it should be less than 7% of the calories. Then we have the polyunsaturated fatty acids. We say roughly about 7 to 10% of the calories from polyunsaturated. Then we have the monounsaturated fatty acids, and we say roughly about 10 to 15% of the calories should be from the monounsaturated. So we try to make a combination of types of food so that the amount of fat you get is limited to 25% of the calorie, and also the type of fat which comes from the diet is also varied, that it's not too much of the saturated, not too much of the, there's a proportion of the mono, poly, and the unsaturated fatty acids. So when we are talking to an individual regarding the fat content of the diet, we try to advise if it's a non-vegetarian, the type of fat he gets is the saturated fatty acids. So then we try to tell him to take a visible fat which is high in either poly or monounsaturated fatty acids. So you try to evaluate the diet of the individual and then see what is the type of fat he is taking, and then advise him according to what is the type of oil he should be used for cooking. Normally the vegetable oils are the high in poly and the polyunsaturated fatty acids, except for coconut oil and palm oil. But groundnut oil, gingerly oil, safflower oil, all these are acceptable. And the saturated fatty visible fats are usually butter, ghee, dalda, and the coconut oil. So of late we are giving emphasis to trans fat also, which is supposed to be harmful, and these come from the fats which are used or modified for making better fats for cooking purposes, like dalda and so on. So these are avoided, and many of our fast foods have a high percentage of trans fat, so we try to discourage a person who's diabetic to take many of these fast foods very often. So that is roughly the proportion of carbohydrate, protein, fat, and the types of food which contribute to the diet. Now, when we speak in terms of a diabetic diet, it's not a diet which you can use for a day or two, or say 1 week or 2 weeks. This is a diet which has to be carried on for the rest of your life. So the diet has to be adequate in terms of all other nutrients, and the only nutrient which we modify is the calorie. Diet has to be adequate in protein, minerals, and vitamins, otherwise you'll find the individual will start with other deficiency problems. So when we speak in terms of a diet of a diabetic, it has to be planned in such a way that it is nutritionally adequate and will be adequate for all the individual's needs for the rest of his life. And so an easier way to remember a diabetic diet, or to see that minimum it's balanced and you get all the nutrients which are required, is to think of the diet in terms of the type of foods or we are normally consuming. Normally we consume foods like cereals, which are our main source of carbohydrate and calories. Then we think of the dals, which are a source of protein in a vegetarian diet, and the non-vegetarian group, which are also source of protein. Then we think of the vegetables and fruits, which contribute to a large extent of the minerals and vitamins, and also a group of nutrients which are known as antioxidants, which are very helpful now and prevent a lot of lifestyle diseases like cardiovascular, cancer, and so on. So it's very important to have an adequate intake of antioxidants in the diet. And then we think in terms of milk and milk products, which again are source of nutrients, protein, and vitamins. So basically a diet should be based upon cereal, non-vegetarian or dal foods, vegetable and fruits, and milk products. Now the other two contributing sources to calories are the sugars, which again is something which gives you flavor and makes food tasty, and fats and oils. Now these two we classify as empty calories because they give you only calories and nothing else. Now sugar and honey, glucose, all these give you carbohydrate and calories. If you take oil, ghee, butter, etc., they give you fat and they give you calories, but they don't give you anything else. Therefore, at least most of the important factors. So therefore, we try to advise, say these are empty calories and you consume them to as minimum a quantity as possible. Now sugars we normally don't advocate because diabetics find it very easy to cut off sugar from their diet, and that's one of the things they very happily agree to do. But when you say to reduce the quantity of other foods, they hesitate so much. So it's no problem to reduce the sugars in the diets, and people get used to eating and drinking coffee, tea, etc. without sugar. And there are sugar substitutes in consultation with your physician you could always use. And fats and oils are mainly used. It has a role in terms of palatability of the meal. Now, as all of you know, if you go out to eat a meal in a hotel, how delicious it is. Now this is mainly because of the rich fat and ghee and which is put into that dish, and therefore it makes it very tasty, but unfortunately we are getting a lot of calories. And once we become a diabetic, we have to be very conscious about the calories we take. So if you are eating out, say once in a week or once in a month, there's no problem. But it's just that you shouldn't make it a habit of eating out often, because a lot of this fat comes into your diet unknowingly, and this contributes to your calorie. So when you reduce the fat in the diet, you have to accept the fact that the food may not be as tasty as you have been used to. But you have to accept this. You have to motivate yourself to accept it because it's needed for control of your disturbance, and therefore you have to accept it. So basically this is the factors we consider in terms of nutrition, that your calorie is reduced to see that you maintain or achieve your desirable body weight. Then you see that the diet is adequate in terms of all other nutrients. So we say normally in these type of foods as a minimum requirement. So cereals depends upon the calories, but roughly we say 6 to 8 servings per day. And vegetables and fruits, we say you must take at least 4 to 5 servings. Now, to prevent cardiovascular diseases, to have a lot of antioxidants in your diet, the recommendation you have is that you must take at least 500 grams of vegetables and fruits a day. Now, are you visualizing how much is 500 grams? That's roughly half a kilo. Invariably, when you ask people how much vegetable they cook, they will say 1/4 kilo and divided by 6 people. Now, when you say 400 to 500 grams, that means at least half a kilo of vegetables and fruits a day, which may be 2 oranges and 2 to 3 servings of vegetable a day. Now, this is very important because this is necessary for giving you satiety in the diet. It's necessary for all the nutrients in terms of vitamins, minerals, and also it's very important in terms of antioxidants in the diet. So this is gaining more and more emphasis, and I think in our basically an Indian diet, our goal should be to increase the amount of vegetables and fruit intake, and especially the vegetable group, because I find personally that the intake of vegetable is very, very poor in the Indian dietary pattern. And so basically in a pattern in a diabetic, what we normally see is from the average individual's intake, what he has to do is modify or avoid the intake of sugar totally, which is an empty calorie, reduce the amount of fat in his diet, reduce the amount of cereal he takes. Normally they take 80% of the diet is from carbohydrate, and this normal intake is about 10 to 12 servings per day. Now this has to be cut to 6 to 8, and you know what is going to happen for that. You'll feel hungry, and therefore how do you fill up the make yourself feel happy in terms of satiety. So normally what we tell the individual is that you serve yourself. See that half your plate is filled with vegetables in your plate. Quarter of the plate will have a serving of, say, non-vegetarian or dal, or say curd and milk or milk products, and the rest, maybe 1/3 of the plate, will be your cereal. If you try to maintain that and take an equal amount of cereal as an equal amount of vegetable, you will find you will be able to maintain your satiety than to first take cereal. And another important tip is that you take a definite quantity now how much of cereal you should take to maintain your carbohydrate intake, and you see that you measure that amount first, or keep apart that amount of cereal, and don't keep on taking from your serving plate all the time. Now this is roughly the way we calculate the nutrient intake. Now if you go down to individual diet, how to plan the diet basically, as I said, not only is the carbohydrate controlled, calorie is controlled. In addition, we have to see that the intake of food is timely. Why? Because whatever we eat is the one which releases the sugar into the bloodstream. So we eat too much at one time, there's a large amount of glucose coming to the bloodstream. Whereas if we eat too little at one time, there's no glucose coming to the bloodstream. And one of the factors we try to avoid is either hyperglycemia or hypoglycemia. Both are equally harmful. We try to maintain the patient at what we call euglycemia or normoglycemia, that is as close to normal as possible, and not have peaks of high and low. So that is why we try to regulate the carbohydrate intake at regular intervals. Now if it is a non-insulin diabetic, normally we say the calories can be divided fairly equally between the meals, that is breakfast, lunch and dinner, keeping a little calorie for your snacks in between, or according to what the patient is accustomed to. Maybe he has a heavier breakfast compared to lunch and so on. That could be adjusted for a non-insulin dependent. But for an insulin dependent diabetic, it is very important that the carbohydrate intake is controlled according to the peak activity of insulin. So this is more carefully regulated, and here we actually think of the carbohydrate intake of the patient, and we speak in terms of carbohydrate counting, and we try to see that it is divided fairly equally for the 3 meals with in between snacks. Now it is more acceptable not to have 3 large meals, but to have 3 meals with in between snacks, and this prevents peaks of hyperglycemia or low of hypoglycemia, and this is very important, and a factor which a person who has diabetes has to remember, that this has to be followed every day, not just one day. You can't afford to fast, you can't afford to feast. Both these are wrong. So you have to see that every day you are very regular with your meal timing, and every day the intake of carbohydrate is fairly regulated, and this is important if you want to control your diabetes, and especially if you're an insulin dependent diabetic. Now after you follow this dietary pattern, then you must follow and see whether you're able to achieve what you have set out to achieve, that is whether you have lost the weight you desired, whether your blood sugar levels are controlled, whether your lipid levels, if any level was high, whether that has also come down to normal level. So this should be monitored. If not, in consultation with the doctor and the dietitian, you should see how to modify your diet, or maybe take something else, medications to control your blood sugar. The key factor is that the blood sugar level is controlled. Yeah, I've been just telling you about basically the principles of planning the diabetic diet. Now to make it more realistic, I think if we go down to a specific example, it may be more realistic to you. So we will take just an individual for the information which is given Mr. Shekhar. Now, for instance, you take his height, it's about 165 centimeters. So what should be his ideal body weight? His height in centimeters minus 100, which will be equal to about 65 kilos. And if we try to make his weight to be about 90% his desirable body weight, it should be roughly about 58.5, or you can rough it around and say it's about 59 kilos. So that is his target. But what is his actual weight? That is what his desirable weight for his height. But if you take his actual weight is 75 kilos. Now he's nearly about 15 kilos more than his weight. Now that is a difficult task. Somebody who has been having this higher weight obviously would have been either eating more than he required, or he has had absolutely no physical activity. So we try to evaluate the pattern of, take a evaluation of the past dietary pattern of Mr. Shekhar and take roughly approximate to calories he has been consuming. So we try to calculate and see how much of cereal, how much of dal, how much of non-veg, how much of oil he uses for cooking, how often he eats outside. We try to get a varied dietary intake from him for a typical 24-hour dietary intake, and then calculate and see what was his calorie requirement, what is protein requirement, how much came from carbohydrate, protein and fat of the calories, and then based on that, now we will have to set our goals. So we tell Mr. Shekhar, now our goal is that you should reduce 15 kilos, maybe not in a month's time, but a target of 6 months' time. But we can give him a target that he can reduce at least half a kilo a week. That's quite a reasonable target. So if you want him to reduce half a kilo a week, what we have to do is reduce that amount of calories from the required intake. So you would try to work out how much of calories actually Mr. Shekhar should be consuming. And we use normally the value of, if he can take his weight into 24 calories, will give you the basal metabolic rate of the individual. Now what is this basal metabolic rate? Now normally an individual's energy requirement or the calorie requirement depends upon two factors. One is his basal and one is the activity. Now basal is for all the involuntary activities which go on in the body, like the heart rate's going on, your functions of the liver, all these various activities go on in the body is the basal. That's a basal expenditure of energy in a state of rest. Now whatever is the voluntary activity you do, like for instance walking, moving, jumping, all this needs extra energy, and this is the activity energy required for activity. Normally we have various ways of calculating this. Roughly we say if you are doing sedentary activity, like mostly sitting at a desk writing something, hardly moving about, this is called sedentary, and we say roughly 20% more than the basic, it is what is the requirement for sedentary activity. Now if you're doing moderate activity like walking to the bus stop, say twice a day, and then doing some work in the house, not just sitting all the time or reading, and your hobbies are not just reading, in that case we say it's moderate activity, and we say roughly you need 30 to 40% more than your normal requirement. Now if you're doing very strenuous activity, like you find the laborer who's actually working in the field and working in, say, digging pits and so on, now his activity is much harder and therefore it's more strenuous, and therefore we increase the activity proportionally to 50 to 100% more than the basic. So this is how we work out the total energy requirement of an individual, what his basic requirement is plus what is required for his activity. Now we presume that Shekhar is having sedentary activity, so we have calculated his basal, which is roughly, you can use 1 calorie per kg per hour, which is roughly 24 calories in a day, into his weight, which is 75 kilos. So his basal energy required is about 1800 kilocalories. Now 20% more than this or 25% more than this can be added for his activity factor, which works out to about 450 kilocalories. So actually his requirement is 2250 calories to maintain him at the weight he is normally at, he is now. Now we try to take the past history of the individual and see what was he taking. Was he taking 3000 calories? Was he taking only 1500 calories? Or was he taking 2500? Based on this, we set our target on reducing weight. So roughly we say if you want a person to lose half a kilo per week, we reduce 500 calories from the daily requirement. And this target can be worked out only along with the patient, because he has to accept the reduction in the calorie intake. He has to accept that it is possible for him to follow it, and it has to be a workable or a feasible plan. Otherwise he will follow it for 3 days and he will discontinue the diet within another week. So we set the targets by making the client himself decide how much he can lose, how much calories he can reduce in the day, and then we try to help him to make this reduction in his diet. So if we set our goal that Mr. Sekar should reduce half a kilo a week, we reduce 500 calories from his daily intake, and therefore his daily optimum requirement when we plan a diet would be roughly about 1800 calories per day. Now this is the first step. Now mind you, this step has been taken along with the individual, and he has accepted that he's going to reduce 500 calories per day, and it is possible for him to do this. So now we help the individual to decide how he's going to bring about this reduction. And so we help him plan the diet. Now basically we try to divide these calories between carbohydrate, protein and fat, and work out so that 65% comes from the carbohydrate, protein 10 to 15%, and fat 20 to 25%. Now this again depends upon the economic level. Now if people are from the higher income groups, normally they will spend much more in terms of protein and fat compared to carbohydrate, and they can bring it down to 60%. But if it is from the lower income group who mainly eat just cereal, say rice and dal and sambar and nothing else, then for them reduction of carbohydrate will be more difficult, and we try to give them at least 65% from the carbohydrate intake. So this is dependent upon the patient's past intake. Now based on this, then we try to divide the calories for carbohydrate, protein and fat, and we work out into a proportion of so many grams of carbohydrate in the day, because each gram of carbohydrate gives you 4 calories. Then we work out how much of protein is required in a day. Each gram of protein gives you 4 calories. And then we work out how much of fat is the requirement for the day, which each gram of fat gives you 9 calories. So based on this, now we have to plan the diet. Now in planning a diet for a diabetic, as I said, it is a lifelong planning, a plan which you have to maintain for the rest of your life. Therefore, we plan the diet in terms of what we speak of as exchanges. Now this is done in exchanges are done so that we group the foods into groups where the composition is similar in terms of carbohydrate, protein and fat, because our main concentration now is on carbohydrate, protein and fat, and therefore we group the foods into various categories depending upon the carbohydrate, protein and fat composition. So roughly we may have a cereal group, a dal group, a milk and milk product group, a vegetable and fruit group. Now vegetables could be of 2 types, could be vegetables which give you more calorie for a lesser amount and less calorie for a less amount. So we usually group them into 2 groups, A and B. The A group is usually the ones like the leafy vegetable, which has more of water percentage and therefore the calorie will be less, and the B group will be ones which are more denser and therefore the calorie will be more. Now normally in a diabetic diet we try not to make too many restrictions. So if you try to restrict the individual so much in terms of all the items, it's very difficult to maintain. So in terms of vegetables, normally we say eat plenty of leafy and green vegetables, eat plenty of salads, only avoid the root vegetables. But we try to restrict the cereals and so on. Now we put the items, now for example in a cereal exchange, and you decide an individual based on the calorie, grams, protein, etc. He needs say 6 or 8 cereal exchanges a day. So we know the total amount of cereal exchanges an individual needs. His diet may have say 8 cereal exchanges, may have 2 non-vegetarian exchanges, may have 2 dal exchanges, may have milk and milk products about 3 to 4 exchanges, and will have vegetables and fruits maybe 4 to 6 exchanges. Now this depends upon the calorie, how much of carbohydrate, protein and fat you need. It can vary according to the individual's background and what his pattern is. Now once we decide, now for instance the person needs so many cereal exchanges, then you have to remember the distribution of this between the meals. We have said that the carbohydrate should be distributed throughout the day. So then we decide that how much should be taken at breakfast, how much should be taken for lunch, and how much should be taken for dinner, and what is to be kept in between meals. So if it's a non-insulin dependent diabetic, out of the 6 it could be taken as 2 to make 6 cereal exchanges. 2 cereal exchanges breakfast, 2 cereal exchanges at lunch, and 2 cereal exchanges at dinner, which will make 6. Now, depends upon the calorie. Now, if you want 1800 calories, you can give 3 cereal exchanges at lunch, 3 at dinner, and 2 at breakfast. Now when we tell the patient, now we try to make him understand, now for breakfast you can have 2 cereal exchanges. Now why do we say cereal exchange? Because when we say exchange, we include all foods which are similar in composition. So we write down a list of foods which are similar in composition. It could be say 2 idlis, could be 2 chapatis, could be 1 cup of rice, could be say 100 grams of potato. We list all the items which are dense in carbohydrates and will give you the same amount of protein and fat, and give down the list so that he can vary himself every day. Otherwise what happens is diet tends to get monotonous. I can't tell him eat idli every day. Today he may want idli, tomorrow he may want dosa, or day after he may want upama. So we include all the possible items in this exchange. and then give it to him so that he himself can vary his diet and choose according to what he would like to eat. And similarly, we plan in such a way that at least there will be a cereal exchange, a milk and milk product exchange, a vegetable and fruit exchange, and if you're a non-vegetarian, non-veg exchange in one meal. So we try to make all the meals balanced. Breakfast should be balanced, lunch should be balanced, and tea should be balanced. And not tea, dinner. So we try to see that each meal is a balanced meal where you have a cereal, you have a protein source like either a dal or a non-vegetarian, you have a milk and milk product source which gives you your minerals and vitamins, and then you need your antioxidants and vegetables and minerals and vitamins, which comes from the vegetables and fruits. Now, for example, you have a fruit at breakfast, you can have vegetable at lunch. You can have a fruit at tea time, you can have vegetables at dinner. So this is very important to see the meals are balanced, the nutrients are distributed throughout the day and also during the various meals. And this is important. So based on that, we try to explain to the patient the exchanges, what is the significance of exchanges, and try to give him a diet plan based on that. And the individual himself feels he has the freedom to vary it as much as possible. And therefore, he is more happy with the diet and it prevents monotony. So that is why a diabetic diet is always planned in terms of exchanges, so that the individual himself can alter or change his diet to prevent monotony, at the same time seeing that the carbohydrate distribution is not disturbed and the calorie distribution is not disturbed and the diet is adequate in terms of minerals and vitamins.